Morning, everybody, and welcome to Pediatric Grand Rounds and also to Resident and Fellow Research Day here at Seattle Children's. I'm Suzanne Mazur. I'm the director of CME here at Seattle Children's. And turn over the microphone, the virtual microphone, to Dr. Walker Harding, who's the chair of the Department of Pediatrics here at University of Washington and Seattle Children's, to introduce our speaker. Thanks so much to our speaker and to Dr. Walker Harding.
Thank you so much. This is such a pleasure. I'm extremely honored to introduce Dr. Fernando Mendoza for our Resident and Fellow Research Day keynote speaker and guest, and as our Grand Round speaker today. I have been privileged to know Dr. Mendoza for a number of years. We've gotten to work on a few committees together, write a few papers focused on workforce diversity, call to action on diversity and inclusion within the pediatric world, and health disparities, all topics that are clearly related. And on top of that, he's given me some amazing sage advice as I've worked through my career. So it is such a pleasure to have him here. Dr. Mendoza is the Associate Dean of Minority Advising and Programs and Professor of Pediatrics at Lucille Salter Packard Children's Hospital at Stanford University. And he also has the status now of emeritus. He was the division chief of general pediatrics for almost 20 years and has been in the past a fellowship director of the Academic Pediatric Fellowship. He has served as the principal investigator for the Center for Excellence for Diversity in Medical Education since 1992. He has had numerous awards from national, local, very local, and he is currently, I can't even list them all, there's so many of them. He is currently a council member of the National Advisory Council for NIMHD, and is a regional and recognized a national leader. He actually has been named in the past one of the 100 most influential Hispanic people in the U.S. He very proudly is a product of the Bay Area and grew up in San Jose, as I did. And he started his academic career at San Jose State University, where he got his BA, and then spent the rest of his medical school residency and fellowship at Stanford University. He left once to go to Boston to get his MPH at Harvard, but has come back to the Bay Area and dedicated his activism, excellence in research, and life's work in that area. He has numerous publications. Many are on immigrant children, diversity and inclusion, the workforce diversity, particularly in academic pediatrics. And he's in journals that span from science to JAMA to pediatrics to even surgical journals. Whenever I see him, when we used to be able to travel, he was always going someplace else. He's a very in-demand speaker and advisor as people try to struggle with what we need to do better with immigrant children, with diversity, equity, and inclusion in the workforce. So it is with great pleasure that I introduce Dr. Fernando Mendoza, who's going to be speaking on the health of children and immigrant families, vulnerable children, and the nation's future. Thank you.
Thank you, Leslie. My mother would be proud of that introduction. I have no disclosures. Our nation's at a crossroads, and it has been a terrible year. We've seen immigrants flee violence, children in cages. We've seen the COVID-19 impact 100,000 people that have passed away, many of those in the African American and Latino communities. And now we've seen the deaths of George Floyd, Black women, men, and children. So before we start talking about immigrant children, I'd like to at least have a moment of silence for all the people that have suffered and died. Thank you. What I'm going to talk about today is immigrant health, immigrant children in the United States, but also children in immigrant families. And I'll mention that that group is growing even every day to a larger proportion of our population. In order to kind of understand what's happened with these children, I'd like to at least walk you through some important issues that I think pediatricians need to understand. First is the U.S. history of immigration, and I'll start from personal background and family history of that to the national scene, the changing demographics of our nation as a result of immigrants, risk profiles for refugees at the border, and what is happening with them. What is the characteristics of the children in immigrant families in this country, and how does that impact their health? Characteristics of their health overall, but more importantly, an interesting finding that we call the immigrant paradox, how the environment of anti-immigrants has hurt the mental health and school performance of children in immigrant families. And lastly, speak about what is the role that we have in this process. When I grew up in the 1950s, this is what I was told, that America was the place for immigrants to come. The Statue of Liberty would welcome everybody. And I thought that that was true. Yet the reality is we kind of looked into the history and found that immigrants do come, but they're not always welcome. And in that context, there's many stories of families and areas of the country that have seen immigrants suffer. Even in Wisconsin, there was, Germans that came to settle that area. They were discriminated against. And in fact, bilingual education started in there for children that were speaking German. So we have a very complex history. But I can reflect upon my own history. This is my grandfather on the left. He fought with Pancho Villa, got shot 4 or 5 times, so decided it was probably time to leave. He came to the United States, worked on the railroads, and as a farm worker, also in the farms. My father is in the middle there with his little gown. When he grew up, he went to a segregated school in Southern California, where if he spoke Spanish, he would be hit. On the other side, my mom was born in El Paso, Texas, a U.S. citizen. In 1933, she recalls that she was in a plaza in El Paso, and immigration came, picked her and her family up, and took her to Mexico. In the 1930s, because of the Depression, the United States started to deport Mexicans back to Mexico, Mexican Americans back to Mexico. Even if you were a citizen, you got deported. My mom was deported as a young child, and what was interesting, what was interesting that she said that that was the most traumatic issue in her life, that deportation of being an American citizen and being taken back to Mexico. So these are histories that we all have as families, and it really does impact how children grow up. So what has been the history of the United States? And I think the one word that I would use is really controlling what the country looks like. That's the issue of immigration laws, who becomes citizens, and how does the demographics of the United States look and stay in a certain condition as such. The first laws were done in 1790, and they were allowed only free white people to be of good moral character to be citizens. In 1982, in 1882 rather, there was the Chinese Exclusion Act. This came about because of the increased numbers of Chinese workers in California that was seen as a concern that the population would become too Asian. So that law was passed by the Congress and wasn't changed until 1943. In 1886, the 14th Amendment gave Civil Rights Act gave African Americans citizenship. But interestingly enough, it did not give Native American citizenship until 1924. After World War I, there was certainly a number of immigrants that were coming to the United States, but because they were from certain countries that people in Congress didn't feel like they were appropriate for this country, the 1924 Origins Act was passed, and there was quotas of who could come from certain Southern and Eastern European countries, and it virtually eliminated Asian Americans. This really continued until 1965, during the time of civil rights. It was then assessed as we needed to do something different. We needed to give the context of what the Statue of Liberty said, inviting immigrants to this country, a new law. So in 1965, immigration law was passed that removed the quotas and really looked at family reunification and trying to kind of make it more fairer for other families. Throughout the years, though, there have been continued efforts to kind of manipulate the immigration laws. Many of those have actually been important to really bring fairness and provide opportunities for those that needed to come to this country. You see them here that they, with the Refugee Law Act in 1980, that allowed more immigrants to come, or refugees particularly. Initially had been 17,000. It was raised up to 50,000. There were also temporary protections that initially started in 1990, redesigned in 2002, and put into the Homeland Security at that time. But one of the interesting things, you can see the countries that were allowed to bring or to allow refugees to come from those countries are the countries we now determine should not be allowed to come to this country as a refugee: El Salvador, Honduras, Nicaragua. So sometimes this is, good law, and sometimes it's not so good law. Human trafficking was also put in. In addition to the Congress, the Supreme Court has also been involved. It provided in 1982 the opportunity for all children to get educated, independent of whether they were undocumented or not. And there's been a number of executive actions. This has not been uncommon. You see all those presidents listed there. But probably the most significant more recently has been President Obama's efforts to allow undocumented children that have been brought here as children to stay in the United States, the DACA program. So what has this done to our country's demographics? You can see on this chart, in 1960, the yellow is European, the green is North America, which is mostly Canada, Latin America, blue, Mexico, Africa, and Asia. 1965, laws changed, and you see what happens. The demographics of the immigrants coming to the United States change. And in 2018, most of the immigrants are coming from Latin America and Asia. That has had that along with birth rates, has had a real significant change on our demographics. The line that you see, the dotted line here, is 50% of the population of the United States. The red line is the number of minority children in this country, minority children and youth, and they would look like this. Half of all the children in the United States as of 2018 are a minority. That number will continue to grow. And as they become adults, you'll see that half of all the citizens or the people in the United States will be minority as of about 2044. So our country is changing demographically, and there's nothing that any wall will be able to do to change that. This will be the future of our nation. Part of that future, as you see here, also includes immigrants. Currently, 1 in every 4th child is a child in an immigrant family, which means that one parent is foreign born. In 2050, this will be increased to 1 in 3. But for Latinx children, one sees that they are probably going to be proportional by 2040, 2050 or so in number to non-Hispanic whites. And the reason for that is not just because of immigration, but because of the higher birth rates among Latinx, Latino, and Asian Americans. Without the high birth rates or the higher birth rates of Asian Americans and Latinos, there would be a decrease in the number of children population in the United States. This diversity then has led to a couple of things. One clearly is language changes. That is, the number of languages spoken in the United States has significantly increased. There are 350 languages spoken in the United States. And if you look at metropolitan areas in which most of the medical centers, the big medical centers are based, many of them have more than 100, 150 languages. On this side, we have the number of languages, and here we have these little dots are the population in millions. I would point you to Seattle, that you're here in your area. There is listed about 170 languages, and this was in 2013, probably more now, and the barrier here. That really impacts how we provide care, how we do education, how we do research. Beyond, though, English and Spanish, one of the interesting findings is also that the country has many different languages spoken. This map I thought was interesting because if you look at it, if beyond Spanish language, there are many other languages that are spoken, some of those from Europe, some of those from Asia, and then in areas where Native American populations exist, there are Native American languages. That all then impacts us as faculty, as trainees, as people doing healthcare. And I want to point out the differences of the demographics in each of our areas. Here's the United States. This bar, the black slash bar here are white, non-Hispanic whites. This is non-Hispanic blacks, Asian Americans, Hispanics, and then we have Native Americans. But in addition, I've listed here those that are foreign born and those that are non-English at home. They speak another language. California clearly is more diverse than the rest of the United States. But within California, Santa Clara County, where Stanford exists, is the most diverse county in all of California. So as I as a researcher and teacher look at what do I do when I train people, this has to be in my thought process. I put Washington here and your county, and likewise, your county is more diverse than the state itself. So let me start by talking about refugees and their concern. One of the things that we have is that refugees are just all over the world, and they are certainly very concerned because they, are children that are suffering. This shows you the number of children that fit into that category, at least at the southern border. There are about 70,000. These are the children in immigrant families in the United States. The difference between an immigrant and a refugee, as defined by the UN High Commissioner, is that an immigrant moves because they want to have better economic situation for their families. The refugees have to move because they fear for their lives or their freedom. So when we see people coming to the southern border, it's because they fear that they go back to their country, they're going to be killed. And I've had interactions with many people at the border and here, or at least in the Bay Area. And these are the stories that we hear. Now, while we as a country really have not had major policies until more recently, the UN had policies since 1951 on immigrants, or refugees rather, and the protection. We did some of that in 1965 with our Reform Act of Immigration, but really it was until 1980 that we joined the rest of the world with the UN refugee status laws to really look at how we could protect refugees. The goal of that law was really to allow the president to have at least 50,000 refugees per year be admitted to the United States. It also set up a U.S. coordinator for refugee affairs, an Office of Refugee Resettlement, so refugees could come to this country, allowed to become part of our country and be resettled in a systematic process. What has happened over the years is the refugees that we've been able to take in, we see here in blue, and we had taken in more refugees than any other country. These are the other countries. That was the situation until 2016, as you see here. This bar graph shows in the dark blue the ceiling for each year that we said we would like to reach. And the light blue shows the amount of refugees we actually took in. What you see here the last 3 years is that ceiling has come down to today, which is about 18,000. And we've only accepted 3,000. So we as a country have really stopped allowing refugees to come in. Now that process over the years has been linked with what's happened in the world. And what you see is the blue are refugees from Europe, green from Asia, brown from Latin America, and the yellow from Africa. One sees here both the numbers, but also the decreasing proportion from different countries, and a very, very small proportion from Latin America. That said, we have taken a number of immigrants. Each state has the opportunity to take the number it can take in. Texas has been one of those that has taken in the most. You see Washington below that, and California a little further down. But it's happened recently, not just with the immigration laws that have restricted that process along the border. The Trump administration has given each governor the opportunity to decide whether they want to take in refugees or not. And in this case, the Texas governor has decided they want to close that off. So the problem with refugee processing is it not only has national, but it has local, and this sometimes makes it very difficult for any efficient process or fair process to happen. So what we end up with is the scenario that we've seen, unfortunately, children in cages, children in very cold, terrible situations. The evaluation of this group of children shows that if you assess them, almost half have a reasonable humanitarian reason to come to the United States. But what happens is that when they do come, they rarely get any legal aid. In fact, if they have legal aid by lawyers, they have a 50% likelihood of being admitted. But without legal aid, they're most likely, almost 90+% to be sent back home. So one of the problems for these children is that they and their families, that they don't have any advocates for them that really can allow them to stay. So many end up being detained and then sent back home. In that detention, though, there is trauma, likewise, to the children and their families. In 1997, the Flores Agreement, which was a court agreement, was that they should, if they are going to be detained in a way that or rather that they should be released in let me that their detention should be limited, and then they should be able to be processed to either their families or their parents or families or other licensed childcare. So the idea of the Flores agreement was, let's treat kids in a appropriate, sensitive way. That has not happened, and I'm very proud of the Academy, the presidents of the Academy, that have stood up and said this is something that this country should not be doing, putting children in detention centers and treating them like they're inhuman. So I think the unfortunate thing now is that this process still goes on, and we see stories daily on what has happened to these children and the trauma that they're going through. Let me talk about then children in immigrant families in this country. There are, as I said, a quarter, and that's about 18 million. 90% of these children are U.S. citizens. 5% are documented, and only 5% are undocumented. So that's this part here, 800,000. But there's someplace between 4.5 to 5 million children that have an undocumented parent, and that's a high-risk situation. There are 13 million children that live in an immigrant family, and those children are being exposed to the anti-immigrant rhetoric of the communities and the nation at this point, unfortunately, and that has trauma to them as well. How should we look at this issue in terms of immigrants, and how does one then process how we should treat them? What are the things we should think about in providing them health care? I think if we think about precision health and being patient-centered, family-centered, then I would argue that we need to think about how to use the model from the World Health and CDC on the model of health. And what this model does, it really looks at the totality of what makes people and communities healthy. You see, here is the gene and the biology of the patient. Here we see the health behaviors that they have, the medical care. But this whole section here is what one would call is the ecology or the social determinants. And what are those social determinants? Well, these are some of the listed social determinants that we see in the literature. Certainly poverty, low education, race, and ethnicity, cultures, the isms, racism, being disenfranchised from institutions. All those impact the health of the populations of children that we have in this country. And that's whether you're an immigrant or not. But for immigrants, it's the immigration policies that I just mentioned. Yet we also, as pediatricians, need to think about this process on the life course. As I explained to you, what happened to my mother when she was this age, that event affected the rest of her life. And if parents are removed from children, then that will affect the rest of their lives. If children that are in immigrant families are told that they're less, that they're not really Americans, that affects the rest of their lives. So this is a process for pediatricians need to be part of, because we are building this in a way, hopefully, that we stay on this side of the curve, positive growth for kids, and those kids becoming our next generation of American citizens. What proportion of these kids exist in each of these groups that, the population that we currently have? The blue bars here are the proportion among each of the subgroups of ethnic groups here that are in immigrant families. The orange bars are the rest of the population. If I click through this, 8% of non-Hispanic whites are immigrant families, 16% in non-Hispanic blacks. But if you look at Asian Americans, 85% of all Asian American children live in an immigrant family, and that is also very high for Hispanics, more than 50%. Yet their backgrounds are fairly strong in the sense of family structure. This is the two-parent families for first generation, second generation, and then third and later generation, and lower numbers of single parents. This has been very consistent over many years. So it is also, part of their risk is being poor, but the other part of being as a resource is their family structure. And with regard to their background, education is one of those factors that I think is important for us to understand of what educational background do the parents of children in immigrant families have. And what one sees here is that when you look at U.S. immigrants, they tend to have higher rates of being high school only, or and lower rates of being in college. But the biggest group from Mexico and Central America have the highest rates of having high school or less, and the lowest rate of having college education. But again, there is a variability of that in each of the groups. If one looks then at poverty, and education is linked to that, we see here that the number of individuals below the poverty line is highest for the first and second generation. If you look at those groups as they incorporate themselves into the rest of the population of kids, both first, immigrant and non-immigrant children, if you look at non-Hispanic whites, only 5% are in severe poverty, 50% of the poverty line, 10% are in below the poverty line, and 26% are 200% below the poverty line. But Black and Latino kids are very high in this. And so this is an issue both for those that are immigrants, but also those that are US. You see Asian American children here. But I would say that besides education and poverty, the biggest factor is one of whether the parent is undocumented. There are almost 46 million immigrants in this country, and about a quarter of that group is undocumented. And if one looks at the kids in California or Washington, and you ask the question, how many are children in immigrant families? In California, 33%. And how many of those children have undocumented parents? I'm sorry, the population of immigrant children, 1/3 in California have undocumented parents. So the number is fairly high. If you look at then all children in California, 17%, almost 1 in 6 child has an undocumented parent. Here are the numbers for Washington. This is a real major concern for us in California, since every 6th child that I see could have an undocumented parent and end up losing that parent. Even in the Obama administration, we had parents that were deported. In the period between 2009 2013, 500,000 parents were deported. That means 100,000 kids lost their parent. Some of them moved back to Mexico as part of that. This is not great policy for kids, particularly those that are US citizens, and something that needs to be changed. Part of that process that ends up determining whether somebody goes back or stays in this country is whether they use any public benefits. And I'll just briefly touch upon what that means. Here, the issue for the government is there a likelihood for this immigrant to use any funding from the United States rather than working? So will the immigrant be dependent on the government in the future? This really focuses on cash payments. It does not have, though, an effect on those programs that are really not cash-based, so food stamps, Medicaid. But the problem this has is that it ends up causing a lot of distress among families. And if one family member is not documented, there's fear that if another family member uses public benefit, that it will affect them in terms of their immigration status. We recently published a paper because the issue was also for those that are immigrants. Do you move from one state to the other to get better benefits? I was concerned by many governors that if they loosened up some of their uh, policies towards immigrants and providing more services, that they would draw in more immigrants. Our paper showed by using national data that that's not the case, that indeed immigrants go to communities where they have social connections. The current health insurance for immigrants is the following. If you look at the Medicaid, CHIP, and the Accountable Care Act subsidies, if you're a pregnant woman, that may allow you to have some of this, because the idea that the pregnant woman is in the United States has a U.S. citizen, so to speak, in the fetus. If you're a U.S. citizen, there's no problem. Lawful. There's only the issue for some states that you have to wait 5 years. And as I said in the previous study, that didn't seem to be something that was an issue of making people move to other states. If again, if you're a refugee, you have the opportunity to be fully covered by all federal programs, so you get access to any program that the U.S. Produces in health care. However, if you're undocumented, then you clearly don't have anything except emergency Medi-Cal. The Kaiser Family Foundation looked at how many of the children in immigrant families are uninsured. And what we see here is citizens' children, U.S. born, are only 4%, and the highest are those that are undocumented. And so one of the problems that we have for those undocumented, they're not only staying away from federal programs and community programs, but they have limited access to care. This is a study using the National Child Health Survey, and what we see here is whether immigrant families with special health care children have medical homes. And while most of these are Latinx children, and many have Spanish at home, the highest are among the first generation that are uninsured, and that falls. But if you look at also the issue of whether they have a medical home or have a medical special health care need, it is lower somewhat in the first generation, but increases over time. Nonetheless, if one examines the children in need of special medical homes with special healthcare needs, those that are foreign born have almost a 50% less likelihood. And likewise, even if you don't have special healthcare needs, you still have lower levels of getting a medical home. I'm briefly going to talk about the health status of children in immigrant families and the issue of the immigrant paradox. And I'm going to go through this fairly briefly, but just to give you a sense of what we've seen. This is a graph that shows the low birth weights, the blue being in native populations and the red being in immigrant women. This data is from 1998, and it has been pretty consistent for the last 30 years, and even now, that immigrant women have lower prevalence of low birth weight. And this is also true for infant mortality. If we look at obesity, immigrants have lower obesity rates than non-immigrants. And that has been, again, consistent. If you look at other conditions, and this is a study by Singh that looked at the National Survey of Children's Health, while obesity was at least reported, this is all by report, you see the rates of asthma, behavioral problems, depression, and school absenteeism having much lower rates. The only one that is higher is that of the perception of poor health. And the question about this is this poor health issue not physical but mental? Is it because of stress? Or is it also because there are differences in how one thinks about health and wellness? These concerns that, or at least this observation that these populations, particularly Latinx, that are poor, have less education, less insurance, yet they seem to do better in their health, has been called the immigrant paradox. And so this has made us think about that poverty may not be equal for everybody, that there are other aspects besides being poor that may help or make a person resilient to being in good health. So I think what this these findings have indicated that we should think about health as not just the state of being poor and not poor, but what other kinds of resiliency factors do people have? What kind of human capital do they have to make their life successful? The other thing that this brings up is the issue: should we continue to support people's culture, or should we all try to get them acculturated to the U.S. society? I was on the IOM committee in 1998 that looked at immigrant families. And after 2 years of doing many types of reviews and research on this topic, the committee felt that acculturation was poor for your health, that becoming acculturated to the United States usually decreased the health of immigrants. Yet one process that is really problematic is the issue of wellness and educational success. Having the stress of having the possibility of losing your parent is, I think, one of the most traumatic things that a child can go through. And the research which would verify that. Here we see information that in middle school, children growing up with an unauthorized parents has lower academic achievement, higher withdrawal, higher acting out. By adolescence, they have higher anxiety, depression. By young adulthood, they have fewer years of schooling. And overall, the idea of having the possibility of the parent deported puts that sort of atmosphere in the family that is very traumatic for kids growing up. The research on this has shown that fear and anxiety extends not just to those families that have undocumented, but the issue of the anti-immigrant effect and policies. The environment that immigrants are not really U.S. citizens is something that is really toxic to kids. The chronic stress that this may cause to families has been documented, and I think the other thing is that if you don't believe that the government is there to help you, then you're going to stay away from it. And whether that's schools or other programs, that seems to be the case. There are lower enrollments of citizen children and youth in health programs and educational programs and preschool programs. This is not something that is good for the children or for our country. If we cannot support children that are immigrant families, we're not supporting the next generation of our citizens. So the social integration is really key for these kids. Part of that social integration has to do with the issue of being in school. There's a study actually in Seattle that showed that Asian American and Latino, Latinx children in immigrant families screen higher for depression than non-children in immigrant families. The National Survey on Health Behaviors in School-Aged Children also noted that the experience of bullying was higher in first generation, and that led to interpersonal, social, emotional health problems, substance abuse. And when one looks at their school performance, there are lower math scores from a national study using standardized tests among first generations. Yet, what this also showed is that those are usually due because of low resources in school and low resources in families. This just reinforces the idea that we need to be proactive in making sure all children get great educations, and particularly those most at risk in poverty. All this said makes it really difficult to think about what we can do. But I think one of the issues that that's come about is, policy can have an important effect. We did a study looking at DACA and mothers that were eligible for DACA and their kids subsequently. And we found that those mothers that were eligible for DACA and got DACA had children subsequently that had 50% reduction in adjustment and anxiety disorders. So this is really important because it says that you can make a policy that actually can have a significant effect on the lives of children. And when you make this kind of policy, I think the implications is that it's not just good for the parent or the adult, it has ramifications for children and the future. How do we provide care? How do we mix the idea of families that have cultural perspectives about care and bring them into our treatment centers and provide what we call high quality care? I think it depends on what group you're looking at. Clearly, for the refugee group, we need to be able to look at what are some of their factors that they have to deal with. We have to assess their pre-migration factors. What was their economics and what was their violence? What were the things that made them move? What happened during the process of that migration? What kinds of trauma did they suffer? And then subsequently, what exactly is going on with them now? How are they fitting into the community? Are they finding social support? Do they have people that can help them move through the various agencies of the government to get the resources that they need? These are processes that we all need to be involved with. In addition, I think overall, children in immigrant families have cultural differences. And these are some of the things that I think are really important, is that we as pediatricians need to open up how we interact with these families and think about their perspective about causal and treatment of the illness. There is a process called LEARN, where people are encouraged to think about it as a process of listening, explaining what's going on, acknowledging, having recommendation in a respectful way, but also then negotiating and making sure that we're in line with what the family is thinking. We also need to think about some of the other processes that they may bring to the table, different medications, herbs, and other processes of what they think may be important for their family, religious situations of how they want to be treated. And overall, I think just sharing the process of healing with the family and their cultural context. Overall, I think the Academy of Pediatrics has done a superb job in telling us exactly how we do this. There's a policy statement that my colleagues, Dr. Litton Green and the Council on Community Pediatrics have put together. I would encourage you to read this. It has 300 references. It also has a toolkit that is very useful. And I think the other part is that the advocacy programs of the Academy have been superb, starting with the President Stein and Kraft, who were out at the border making sure that kids that were in cages were actually being highlighted to the rest of this country and to all of us. Yet I think there are areas for improvement. One area is the area of communication and the use of interpreters. I'm concerned that we still don't do that well. We're completing a study where in California, limited English proficient patients, parents, which is about a third of our parents, when they left their physician, 50% said they did not understand what was going on with their child. So this says to us that we have a great need to make sure that children and immigrant parents, that the parents understand what's going on with their child. It does us no good just to give medication and send them out the door unless they know what needs to be done. I think also support for their development is important. Another study that one of my students was involved with found that less than 50% of immigrant parents read to their kids. This is something that Reach On and Read has tried to look at and do. I think this is something that we as pediatricians, as the first social institution that gets to kids in the first 5 years of life, can really be impactful to really encourage families to be part of their education and their children. Connecting to other collaborators, we have the medical legal partnerships, we have policymaker law enforcement that we need to be part of. The other one that I don't think we always think about is diversity in the child health workforce. It's hard for institutions that are not diverse to be connected with communities that are diverse. So I think this is something that we as leaders in pediatrics need to do. In the final analysis, these are all difficult tasks, but my experience is that this can be done. There are advocates in California and Washington that have supported sanctuary states, DACA. Our state has given driver license to undocumented. We have now a statewide health insurance for kids that are undocumented. And some of this started locally. And Santa Clara County was the first county to give all children, documented or not, health insurance. They developed a Children's Bill of Rights where the Board of Supervisors and the mayor said that they would not pass anything in their activities that would be detrimental to children, that they will always look at this. And then I think partnership with the various groups here. It is the community that will make a difference. And I think in that fact is important because really at the end of the day, our country, it's a number of communities. Each community has to work with each other. And I think these are the future faces of our country. And as we see today, America is struggling to understand who we are. So I thank you for listening and open the questions.
We have our first question from Dr. Walker. What do you think are the important levers to change provider behavior to incorporate interpreters as part of the health team 100% of the time?
Yeah, I think, one of the levers is going to be when we have DRGs and other things that make us look at the management of the patient as the total management. That's to say, right now, as long as the patient is seen and treated, we get paid. If we were really responsible for how well that outcome was going to occur, then we'd be perhaps more invested in the idea that we wanted to make sure that the patient understood what was supposed to go on. For example, if we have a transplant patient, we need to make sure that they understand how to use their medications, when to call us, right? If we have a patient with asthma that comes in and out of the hospital, we need to make sure that they understand, when to treat, how to take care of themselves, and when to call us. So I think that, the lever here is as we become more responsible for the overall care of the patient, that's to say, the final outcome of that patient, that is something that is going to drive the issue of making sure that patients understand us well. Kaiser Permanente spends a lot of time in providing cultural competency training for their trainees, for their physicians, that is, because they understand that when patients return are not kept healthy, it's the cost of the bottom line. So, we've tried altruism, that this should be the right thing to do. I think financing is probably going to be the way that this moves forward.
And from Dr. Walker Harding, thank you so much for an outstanding talk. And we have much to do. We all do. Now we have several more thank yous. So thank you so much, everyone, for being here. Thanks for making it through our WebEx presentation. We really appreciate you being here, and have a great rest of research day for the residents and fellows. Thank you so much. Bye, everybody.
Thank you.
See you next week. Thanks, Dr. Mendoza.
Yeah.